I think doctors, many of us, are quite accustomed to the concept of death and dying, particularly in some disciplines like oncology, hemato-oncology, patients with blood cancers or other cancers. This is because when we tell people that there is a certain chance of long-term survival, we also talk about certain chance of not making it. That chance of not making it is real. I would say that we are not in any way morbid or feeling awkward to talk about death. Society has the perspective of death as a failure. It is not uncommon for the patient's relatives or the patient to say, I went to a hospital to get treated, and at the end of the day, after a lot of treatment, I still relapse. The first hospital stay, the patient went there and the patient came out alive. So that was very good. The first doctor is very good. And the second doctor saw, and the patient was okay and comfortable, but passed away. Right? So, feels that the second doctor was not good. So I think society still very much thinks in that kind of way, and feels that getting discharged from hospital well and alive is the best outcome. But even when the patient is ready, I do find that sometimes not everybody is in sync. The patient may be ready to go, but the family may not be. Some of the family may be ready, but others are not. Some may be ready, but feel that a little bit under pressure from the other members of the family and feel, I'm also not ready because the rest is also not ready for the patient to go. It is in selected cases where we are able to transition the patient, effectively and relatives effectively into preparedness for death and dying. Then it's a more wholesome experience for everybody. Sometimes it takes many times speaking to the patient, speaking to the family, to kind of get used to the idea. I think where the patient is alone, where the patient is able to make a conscious decision, it is actually easier because we are speaking only to one person. And I find in those instances, patients often make quite rational decisions for themselves because in a sense, they have nothing else at stake. So when it comes to approaching death and dying, they're either very prepared or they are not quite prepared yet and give me a bit more time. In those instances, I find it is actually clearer. But where the patient is not able to make a decision, then it becomes difficult. Because if the patient is mentally incapacitated, the patient is in ICU and no one is willing to and able to make a say or stand on behalf of the patient, that is a very difficult decision for us. Interestingly, not long ago, I had a course with a statistics professor. He was trying to explain that if you make a decision based on statistical probabilities, and if you have made it with the best of knowledge, made your best of efforts in making that decision, what happens after that is a question of probability. The term he used was that decisions are deterministic, outcomes are probabilistic. It doesn't change the fact that it was the right decision at that point of time. So if I say that there is a 20% or 30% or 50% chance of not making it in the long term, that is real because for us, out of 10 patients we see, that means 3 or 5 may not become long-term survivors. Sometimes they may also ask, doctor, how much time do I have left? And really, in terms of how much time, really, what do we know? I am just a human being. I'm just a doctor who has studied for many years, seen many patients, but what right does it give me to determine how long a person will live? I am not God. I am not a deity. And I cannot determine these statistics for you. They're only good for the purpose of making a decision. So I always qualify that. There are statistics that say that, this is an average kind of survival expected if you choose this treatment, or if you don't choose this treatment, if you choose this particular treatment. But however, dumping a group of statistics on them is quite offensive, and sometimes it is quite off-putting to them. If a patient comes and I say, do you know you have a 10% chance of dying, 20% chance of dying? Do you know the average statistics says that in 6 months you may die and stuff like that? I'm not going to do that. We can't do that. We don't do that. At the end of the day, you're not going to be partially this, and partially this. You're going to be one of these outcomes. Now, how you will really fare depends on yourself and factors beyond our control. If we do present statistics, it's only for the purpose of making a decision for the patient. Over the years, having encountered many patients going through death and dying, I find that the boundary between death and life is like a curtain. One moment you can be alive, the next moment you're not. And it's not a big wall that you have to kind of crash through. It just happens. The first experience I had with death and dying, I think, was when I was about 6 or 7. I was living with my grandma and my great-grandma, and of course my parents. My parents were out for dinner that night. And then while I was watching TV, I can't remember what I was watching, my grandmother came to me and said that Lao Zoma, my great-grandmother, was lying on a bed and not moving. And her leg was just off the side of the bed. I went to see, and I saw that she was really not moving. I remember being extremely scared because before that she was, just walking around the house, completely well. She was, I think, 92 at the time. I can't remember what I said or did. Maybe I didn't say or do anything because I remember just hiding in bed, because I was terribly scared. And I didn't know what happened. When my parents came back, then a lot of activities started to happen. In many instances, I also find that there are patients who and their families who can be so grateful, even when approaching death, dying, and the families even after the patient has passed away. One of the most moving experiences I had was when I was a young registrar in the hematology unit, and there was a patient who went through a difficult treatment for leukemia and suffered tremendously when the disease came back. And then he was a young man, and ultimately he passed away. And as I was standing there, I was supposed to make the declaration of death. I really felt terrible, and I felt that we had failed the patient. And I made the call, that patient had passed away. At that moment, as I turned around, the mother gave me a hug. The father also joined in, and I felt, hey, why are you trying to comfort me? Obviously I was distraught, and I was also comforting them too. So all the parents said to me was, thank you for all that you have done, even though I had failed the patient. In my eyes, but in their view, I had not, because I had given the patient the best chance, and also that, the patient was able to, in the last hours, be more comfortable. I think palliative care is extremely important for all patients, whether they're cancer patients or otherwise. But beyond palliative care, there's an element that we have expanded, which is what we call supportive care. And I think palliative care and supportive care go hand in hand. Supportive care is care for the patients even when they are not really so terminal, and where the patient's comfort, their emotional concerns, their social concerns, their family angst that they are feeling at that point of time receive the appropriate amount of support, even as they're going through all this. Not just the physical cancer treatment or the treatment-oriented care. Even at the early stage, that is already important, even from the beginning. So when palliative care comes on board and the transition moves towards it, it becomes a smoother transition rather than saying, you're now palliative, as in sometimes patients might feel, oh, my doctor says I'm referring me to the palliative department, and that means he's giving up on me. So that is sometimes a message that is unintentionally conveyed to the patient. What I always try to do is that even when we refer the patient to a palliative physician, we continue to treat the patient. We continue to care for the patient. We continue to be part of the management of the patient so that the patient does not feel so-called abandoned by the original treating physician. They deal with it better than we can because in the treatment-oriented setting, we tend to focus very much on what's the underlying cause and, trying to treat an infection and stuff like that. And perhaps sometimes the more important thing is the comfort of the patient. Beyond the physical aspects of the patient, one thing I really give my hat off to our palliative care physicians is the way they address the psychological aspect of the patient. They address the social aspects of the family. And not only that, which I've seen them do, is that after the patient has passed on, they deal with the bereavement of the family as well. And that I really very much appreciate because I think it is a calling that, makes them so passionate for this. And I really respect it. One thing about, from us in the medical side is that it was actually good in some ways because some of the meetings we needed to attend, we could do over Zoom. And it enabled us to, in a sense, attend meetings very quickly, almost like teleportation. Once you open your computer, you're teleported to the meeting room, which otherwise you would have to rush to at a great distance away. So that did help to address some of the, and I hope to some extent, some parts of that will be a permanent change. From a patient standpoint, when they are admitted to a hospital, it is challenging because at various points of time, patients sometimes could have one caregiver visit, two caregiver visits, or sometimes no caregiver visits, depending on the extent of COVID in the country at that point of time. And it's quite difficult for patients because it's rather isolating. If someone's admitted to a hospital and nobody visits, it's like, something wrong, And how we compensate for it is through interactions with our nurses, through interactions with different people that the patient can interact with in the hospital setting, but also educating the patient on how they can bring in their devices, their computers, and some kids, their computer games, and their communication devices. And with things like Zoom and all that, it's become quite easy for them to kind of have a face-to-face with their family members. And some of them will just leave the FaceTime or, some video that keeps an open window between them and their home. So it's as if they are just a window away from home. It's been challenging, and we've had to sometimes try to explain to relatives why they cannot come, why they cannot visit. And then they'll say, oh, but, my dad or my mom is, very special because, they have these special needs and stuff like that. At the same time, we have to adhere to requirements at that point of time. We're trying to sometimes find ways to bend those requirements whenever we can, but sometimes we cannot. So certainly, I think patients do benefit from someone to talk to, someone to interact with. But thankfully, because of computer devices and stuff like that, there are ways to overcome that to some extent. I would say that all our patients do affect us in some way. But of course, there's some that affect us more than others. There is a lady that I treated, and she did pretty well after a transplant. Then next thing I knew, she was asking me to see her nephew, who was now down with leukemia, and said, please take care of him because he's a very, very good boy. And I felt a lot of pressure to, make sure that he does well. There was a young pastor who came to see me, and he told me that he would like to live longer to see his son, who was same age as mine, 5 years old, grow up, get married, and have kids. I felt a certain amount of pressure in that. Members from my church have asked me to see their relatives, their father, their cousin, their sister, and I felt, the pressure to make sure that I did all that I can for them. Sometimes complications may happen during the treatment or otherwise. And then I have to think, oh, wow, did I do the right thing, right? Should I have made this decision or made this other decision? Even though I made this decision and it seemed like the best decision at that point of time, maybe I should have, if I've taken the other decision, maybe the patient may have lived a little bit longer, right? A recent patient I had, made a very clear choice that as she was facing the fact that her leukemia had relapsed several times, she made a very clear choice that she would stop treatment. And she made that choice partly because she was already leaning towards it. And then she also asked me, what would you do? And I said, if I was in your position, I would choose the same. I would also stop treatment at this particular point. And so she did. And in that final month before she finally passed away, she really lived life. You saw her get together with all her friends, all her old schoolmates. Even that time was during COVID, so it's a bit of a challenge. So some were over Zoom, some were able to visit her. I could see that she was happy. In the end, when she finally passed away, I think it was with a lot of peace, a lot of preparedness, a lot of readiness to go, and a great clarity as to where she was going to. So I saw that the process of death and dying can actually be something beautiful. It can be actually something that, we don't fear as much, and that not that we rush towards it, but it can actually be something that everybody can grow from. I think treating of patients and managing patients and family does give us some, not all, some leadership lessons in terms of how you might deal with people. I think leaders also need to align people that they lead in a similar way, seeing that we have a common goal and seeing that the leader really cares. The other thing is that we also recognize that we cannot lead the patient unless we know much more. The people we lead need to have confidence that we know the subject matter really, really well, even if we do not always choose to inundate them with the facts. The reason why I embrace some aspects of leadership that I subsequently took on is the ability to impact more people. That means if I can impact the staff under my leadership, the doctors who are following my lead, then in that case, I can impact even more people. I can help to influence their mindset by gentle nudges in encouraging certain behaviors and saying, oh, maybe you might want to rethink this other behavior, and saying, hey, when they do something really well, and say that, yes, really like the way in which you comforted that patient. Really, thank you so much for caring for this particular patient up to her demise. Thank you for making the journey so beautiful and wonderful for them. And by encouraging larger groups, I felt that I could have an even larger impact. I think what we really want as doctors, physicians, or in any profession that we do is not so much about the dollars and cents we earn, right? It's really that we would like to have an impact. We would like to have done something worthwhile at the end of our lives. Similar to what I said about, whether I have 70 seconds, 70 hours or longer left, I would like to feel that when I go, I've fought a good fight, I've run a good race. That, I've done what I felt I should have done. So for that reason, I think whether as a physician, whether as a leader, we want to be able to have an opportunity to expand our impact.